Good morning, everyone. Uh, Today, Agostino will be presenting the case. It is moderated by Professor Puneet Dhar, Professor Shiraz Rathar, and myself. Good morning, Puneet and Shiraz. So can we start?
Morning, yes, please.
Morning, sir. Yes, please.
Good morning to respected teachers. So today's case is a 14-year-old female, a resident of Andhra Pradesh, presented with the chief complaints of pain in the abdomen for last 20 days. So history of presenting illness, the patient was apparently all right till the age of 5 years when her parents noticed progressively increasing abdominal distension not associated with pain. No history of hematemesis, melena, jaundice, or easy bruisability. The patient was evaluated elsewhere with ultrasound abdomen. Patient also underwent upper GI endoscopy with endovascular ligation and was later advised for regular endoscopic surveillance. Over last 9 years, patient underwent endoscopic varicose ligation 9 times, and the last one was done in 2018. So after the treatment, what was the status of the abdominal distension that I would like to know? Then currently, the patient came with complaints of insidious onset, dull aching, mild non-radiating pain in the left hypochondriac and left lumbar region since 20 days, which increased after food intake with a history of early satiety and easy fatigability present. No history of growth retardation, poor performance in school, or delay in achieving milestones. No history of hematemesis, altered bowel habits like constipation or loose stools, abdominal distension, jaundice, or fever. No history of petechia, easy bruisability, or any other bleeding manifestations. No history of recurrent cough, cold, or other infections. No history of shortness of breath, postural dizziness, or blood transfusion. No history of loss of appetite or weight loss. Past history, at 15 days of life, the patient had a complaint of discharge from umbilicus with surrounding redness for which she was hospitalized and later discharged after 1 week. No history of umbilical cannulation. I would like to know whether the baby was delivered at home or in hospital. Family history, no significant family history. Any history of clotting disorders in family, I would like to know. Personal history, sleep was normal, bowel and bladder habits were normal and regular, mixed diet consumer with no addictions. And I would like to know about the menstrual status and the amount of bleeding if she is already started to have menstruation. So summary, a 14-year-old female child who was apparently normal till 5 years of age noticed to have progressive painless abdominal distension and was evaluated and underwent endoscopic variceal ligation and regular follow-up with last endovascular ligation done in 2018. Now presenting with dull aching pain in the left upper quadrant for 20 days and aggravated by food intake and easy fatigability with no history of GI bleed, blood transfusion, fever, jaundice, easy bruisability with normal milestone achievement and no growth retardation. History of umbilical site infection at the age of 15 days requiring 1 week hospital admission. So differential diagnosis is non-cirrhotic portal hypertension due to extrahepatic portal vein obstruction with symptomatic splenomegaly.
So you asked 4 questions which you wanted to
Yeah.
clarify. Can you tell us why you asked each of those here?
So one is status of abdominal distension. Initially at the age of 5, she had a progressively increasing abdominal distension, sir.
So what do you think was the abdominal distension and why do you want to know the status now?
Sir, it will be probably due to the 2 possibilities are there, sir. One is splenomegaly, maybe one cause, sir. One may be ascites, sir.
So is ascites common in this?
No,
in
Age group.
less likely, sir.
So when do you get ascites in EHPVO?
When in the advanced stages, when there is liver failure,
Or
later stage, or rupture of any.
no, or around peri-bleed. If you have bleeding episodes around that time,
decompensation, sir.
you can get temporary this thing, and extremes of age, very young, very old.
Yes,
So it's possible, but usually by and large we don't get it. It's just it's an exception rather than the rule. So status, why did you want to know the status?
So I want to clarify whether that distension was then resolved or it was still present.
Okay, it's because both the things that you mentioned, it would have silently not known. It's in history. You will not know what the status is. So I'm
Yes.
not sure why you stress so much on that. And the second thing you said was,
So second one was deliveries, patient whether
So
patient was,
how will it change your diagnosis or management? You have enough information there. So
yes.
is there a difference at home or in the hospital?
So chances of umbilical cord infection is more likely with home delivery, sir.
This patient anyway had umbilical sepsis
Yes, sir.
infection.
Yes, sir.
So how does it matter then where you got it? So for a lot of things where you already have the information, you do. I've noticed you do. Max, I've seen this in biliary injuries actually. So a lot of there is bile coming out of the drain, but you say I want to know what was the time spent in the surgery. So many of those things become irrelevant when it's already happened. Because whether it's at home or hospital, it doesn't really matter. You could have, I mean, at worst, at the time of the infection, you could have said that hospital one might be more nosocomial infections. I might give a stronger antibiotic, a different antibiotic. But now, 5 years down the line, it's not going to make a difference, isn't it? You already have umbilical sepsis, so it's not so crucial. Clotting disorders in the family?
Even though this patient is having umbilical sepsis history is there, but still some patients can have associated clotting factor disorders, sir.
So what proportion do actually have
So,
been shown to have?
It's very low, sir, and we doesn't need actually routine screening for the same, sir.
Yeah, so actually in Kerala, I know you see a different variety of EHPVO. So we see most of the country actually we see the without the clotting disorders. I know in Kerala you see an adult variant of EHPVO which can be associated with, but a person presenting with at 5 years of age with bleed means the portal vein thrombosis has happened very early in life, at birth. Those are usually not related with clotting disorders, but it's good to know that because worldwide the commoner cause is actually possible or temporary clotting disorder. Okay. And menstrual history?
So age is 14 years, sir. So I would like to know whether she is having polymenorrhea, increased bleeding during her menstrual periods, or whether she is not yet reached her menstrual cycles.
So with
Okay.
what intent? I mean, see, everything you ask should have an intent.
That can be to identify the hypersplenism, if whether she is having any low platelet count
Don't you have enough? Okay, go ahead.
in
Okay, fine.
history.
I think in history we don't have that. Okay,
take,
go ahead.
go ahead.
So on examination, patient is conscious, cooperative, and oriented, moderately built and nourished. Hydration status, I would like to know, sir. Her height is 1.51 meters and weight is 38 kg. BMI is 16.67, which falls in the normal for the age group. Blood holding time 37 seconds, pallor present. No icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Her pulse was 90, BP 160, and respiratory rate was 17. And no features of stigmata of chronic liver disease. Then abdominal examination inspection, abdomen was flat, umbilicus inverted normal in position, visible fullness in the left upper quadrant, all quadrants moving equally with respiration, no visible scars, peristalsis, sinuses or engorged veins, hernial orifices and genitalia appears normal, renal angle appears normal, sir. Palpation, inspectory findings confirmed, abdomen soft, non-tender, liver not palpable, palpable, non-tender, spleen with a smooth surface, with the notch felt on the anterior surface, moving with the respiration and extending till just beyond midline until umbilicus. No other palpable lump. On percussion, liver dullness in fifth intercostal space, liver span 10 centimeter in the right midclavicular line, flanks are tympanic, loss of tympanic node over the left hypochondriac region. And ascites status also I would like to know, sir, during percussion. And auscultation, no normal bowel sounds heard, no abnormal bruit or hum heard. Digital rectal examination, normal sphincter tone, blouse stained with normal feces. Respiratory system was normal and cardiovascular and central nervous system were normal. So it's a 14-year-old female child who was evaluated for progressive, painless abdominal distension and underwent endoscopic variceal ligation on regular follow-up with the last EVL done in 2018. Now presenting with a dull aching pain in the left upper quadrant for 20 days and aggravated by food intake with easy fatigability with no history of GI bleed, blood transfusion, fever, jaundice, easy bruisability or growth retardation with a history of umbilical site infection at the age of 15 days post-delivery. On examination, the child is moderately built and nourished with the pallor present, with stable vitals, having Hackett's grade 3 splenomegaly with no ascites. Differential diagnosis is non-cirrhotic portal hypertension due to extrahepatic portal vein obstruction with the symptomatic splenomegaly with no hypersplenism, portal biliopathy or growth retardation, and is a non-bleeder.
You come back to your whatever red marks you have this thing. So in the so why
So
do
what
you
is, since it's
you are
a,
expecting a hydration, dehydration in this patient? You ask for a hydration status. What do you mean by that?
it's a norm, for GA cases, it will be better to know the hydration status.
See, whenever you ask a question, there should be something behind your thought process, not just
Don't need it, sir.
okay, come back to the next slide. Next.
Next is,
So somebody has written as flanks are tympanic, and then you have written ascites query.
so my knee elbow position also you can say.
So
How many
flanks are
times have you done knee elbow actually? Honestly, in the clinic, in the ward.
No.
So for most things, in this day and age, we'll probably use some other tools to look for that minimal ascites.
Yes,
Yeah.
sir.
Okay. So you want significant ascites is not there. That's good enough to say.
Say that, right?
Yeah.
Yes, sir.
So you should be very clear. If any question you want to ask, there should be a reason behind it.
Yes, sir.
So you said there's no veins engorged, no pulsations, peristalsis, and all that. So this patient had umbilical sepsis.
Yes, sir.
Yeah. So that means the umbilical veins would have been, and possibly also the left portal vein.
Can be thrombosed, sir.
Yeah. So then how come you don't have veins?
Veins will be present in case of IVC or SVC obstructions.
Ooh, that's a different kind of veins, no? So what's the difference in the SVC, IVC, and portal hypertension veins?
Portal hypertension veins will be around the umbilicus, sir, radiating outside, sir.
And normally, what is the direction?
Direction will be away from the umbilicus, sir.
No, that's in portal hypertension. What is the normal flow?
Normal flow will be above the umbilicus, the veins will be going upwards, and below the umbilicus, it will be going downwards.
Which means away from umbilicus also, no? So normal same as portal hypertension?
No, sir. Normal will be around the
Don't
umbilicus.
get confused. Don't get confused. So, when your kids, students ask you, don't get confused by that. Both normal and portal hypertension umbilicus. SVC obstruction?
It will be above, if it is above the asparagus vein, it will be above from up to towards the umbilicus, sir. Crossing the umbilicus, actually.
So how will you describe it? Yeah, you have to be clear about the
The
description.
filling flow, direction of flow will be from craniocaudal, sir.
Above downwards, yeah. So it will be even above and below the umbilicus. It will be all below, and IVC the reverse, isn't it?
Yes.
IVC or deep vein, pelvic vein thrombosis and all, iliac vein thrombosis and all also. Yeah. Okay, that can be unilateral. So, but it will be normal. And you need CLD. You will not get it in simple EHPVO, no?
Yes, sir.
You need
CLD, sir.
intrahepatic, not
Obstruction.
Yeah. So don't get confused if somebody asks you. You should,
See, where is the obstruction in CLD and where is the obstruction in EHPVO?
Sir, EHPVO is extrahepatic, sir. In the extrahepatic portal vein will be obstructed, sir.
So in
In
CLD,
CLD, it will be intrahepatic, sir. Sinusoidal.
so the umbilical veins become prominent in CLD. Why?
Because of portosystemic collaterals, sir.
No, because these veins are patent.
These
It's
veins
the
are
exact
patent,
opposite.
and the block is distal to it. So the umbilical vein marks as an outflow.
Yes, sir.
And comes into systemic vein. That's why you see in cirrhotics, but you don't see in periumbilical veins. You don't see in case of EHPVOs.
Yes, sir.
HPO, the vein itself is blocked, no, so it can't
Blocked, yes,
transmit
sir. Yes,
that pressure in the portal hypertension. So sometimes, when you're setting MCQs, you'll be now soon setting MCQs and all. So you look for things which are the exact opposite as the within the choices. So that if they mark it wrong, then you know that they don't know what they know. So you can't do that yourself, isn't it? Okay, go ahead.
Shiraz.
Shiraz.
Yeah, I had two comments, Agustino. One is that the pattern of history you presented, you present the history of 15 years of pain abdomen and the history of present illness, you went back from 5 years down the line, but at the age of 5 years. So generally, if a patient has a chronic ailment, you better start it with the complaints from in that chronological order. So you could have come from the abdominal distension 5 years, at the age of 5 years, and then abdominal pain, rather than going into recent history and then going into the past. So it gives a bit of a non-continuity in the history. Second thing, in the examination, you said spleen notch palpable. I would not really go for palpation of a spleen notch in a clinical examination, because it's always, most often it hurts the patient. There's no this palpable. Splenomegaly itself is enough, or demarcations are not now necessary in the era of ultrasound being so frequently available. Again, the minimal ascites, we usually hard to elicit on percussion by giving a percussion on a patient or a child. Obviously, if very distended abdomen, maybe you can say that mastocytitis, as Dr. Puneet also mentioned. And you made only one diagnosis, differential diagnosis, and that is like as if, even though we all know, then probably we are dealing with this entity, but I would still keep a chronic liver disease as one of the another differential diagnosis. You have mentioned that there's no stigmata of a chronic liver disease. In some of the children, when they started neonatal hepatitis, they can go up to this age and present in a very insidious onset of a chronic liver disease, where you have very low bilirubin threshold. They may have a splenomegaly. So they may not have a very overt signs of chronic liver disease, but on investigation, you will find out that it is basically a CLD rather than an EHPO. So don't keep one differential diagnosis. It gives an impression that you already know the case.
What is ICC, Indian Childhood Cirrhosis, Agustino?
Recording in progress.
Well, sir, it's a cirrhosis present in the early childhood, sir, with less than 5 years.
Reason for asking is, I know you're not going to be managing these patients, but the reason is, like Shiraz said, it's a good idea not to give a single differential diagnosis. In your mind, it shouldn't look as if you've closed your mind. So you can probably say, put another one and say this is lower down because of this. So would ICC be a DD at this stage or not? You should just be aware of that.
Yes.
Would it? What is the age of presentation?
5 years, sir. 5 years. First time presented in 5 years.
So ICC presents at what age?
Less than 5 years. I mean, around 5 years, sir. Around 5 years.
Actually, 1 to 3 years. It can have, it's not that typical. Read up, because this will be one of your DDs. So read up a little bit about that. How is it different from Wilson's and all that? Because you will, by now, most of your examiners will be, some of them will be transplant surgeons and all that. They might know a little more than you about portal hypertension. So this is one of the topics I've seen in the exam people do badly. So do read up about the background. What is ICC, what age it presents, how does it present. You may not get the full-blown picture of CLD in that, at least early on, like Shiraz was saying. So just be aware of what all you can put in that. Okay, go ahead. What do you want to do?
Sir, I would like to go for the general investigation, go for the general blood investigation, sir.
General blood investigation.
Blood investigation, sir.
We want you to say specific blood. What do you want and why?
Sir, I want the complete blood count, sir.
Why? Why not incomplete? Why? What do you want?
To look for the total count, differential count, platelets, and hemoglobin and PCV, sir.
Why?
Sir, to look for hypersplenism, sir. To look for hypersplenism.
Because in your diagnosis, you said symptomatic splenomegaly without hypersplenism. Why did you say that?
Sir, because there was no features of recurrent infection or no features of recurrent bleeding, easy bruisability or increased bleeding, sir. So possibility of according to history and examination, it was less likely, sir.
Or bleed itself. Okay, HB also. Okay. So can we
can hypersplenism be present without symptoms?
So I couldn't hear it.
Can you get hypersplenism without being symptomatic?
Yes, sir. Yes, sir.
So I mean, the term usually is symptomatic hypersplenism, not symptomatic splenomegaly. Okay.
Yes, sir.
Okay. I mean, you can have pressure symptoms and all that, like they asked about feeding and all that. Yeah. Okay. So
Sir, then I would like to check for this LFT, sir. Liver function test, complete liver function test.
why?
Uh, since the patient was present in at the age of 5 years, I would like to know whether she is progressing to chronic liver disease.
Only chronic liver disease. Anything else you can get a clue in LFT?
And portal biliopathy, sir.
Okay.
Sir, HB 7.9, total count is 1930 reduced, and platelet is
No, you
50.
just interpret. You just interpret because we
Yeah,
can,
sir.
all of us can see the reports. Just
Sir,
what you want is interpret.
so there is pancytopenia, sir. All the 3 cell lineages are decreased in count, so there is hypersplenism, sir.
So significant. You must also give a adjective, no? There's
Does
significant.
hemoglobin 7.9 means RBC count is low?
No, sir. Hemoglobin, that can be because of nutritional or even bleeding can be one cause, sir. Slow bleeding from varices also can be. So we like to see the RBC count actually, sir. Complete CBC comes with RBC.
So what is the how will you differentiate the causes that you just said? Which
Sir, we have to look for the mean corpuscular volume also, sir.
what will that tell you?
Peripheral smear will be better, sir.
What will MCV tell you?
A low MCV indicates probably iron deficiency, nutritional, sir, or long-standing blood loss.
Or
And
thalassemias and all also, okay?
large MCV, I mean, high MCV may be because of vitamin B12 deficiency, sir.
Or folate, okay? What else? MCV, what else?
Then any
MCHC also, no?
sir,
Hemoglobin concentration.
hemoglobin concentration, sir. That will be
Hypochromia.
yes, sir.
Same, similar thing, okay? Thalassemia and deficiency.
Thalassemia.
Yeah. What else? Specifically, what else can you tell? You said a lot of other diseases. How will you differentiate it from that? So,
Sir,
I mean, if it's not inadequate production, if it's not, so basically what is happening in portal hypertensive
increased
what is
destruction.
happening?
Increased destruction of the.
If it's not increased destruction, what will you have? If it's inadequate, how will you differentiate inadequate production from adequate production?
Reticulocyte count we'll look for.
Yeah, so retic count is the easiest in the CBC itself that you'll get. Okay. Okay, and what about TC and platelets?
TC is reduced, sir. I would like to
Significantly reduced.
significantly reduced, sir.
Okay, okay.
And platelet count is also reduced to 51,000, sir.
Okay, so normally we say symptomatic hypersplenism, but when the values are extreme, suppose the the neutrophil value is how much in this? Would you want to know? You can get dangerous infections also, isn't it?
Fatal infections, recurrent infections can be.
Okay. What else do you want to do now?
I would like to get the complete LFTs, liver function tests.
So
What do you expect? LFT?
LFTs are
This
there
patient.
is indirect hyperbilirubinemia is there, sir. Then
You expect to be normal or abnormal?
LFTs are due because of the total bilirubin is increased, sir, with indirect hyperbilirubinemia. That is possibly due to increased cell destruction, sir. Hemolysis. Direct bilirubin is normal, and SAP is also appears normal for the age, sir. And her albumin is also 4. INR is 1.4, sir. So it's suggestive of increased hemolysis.
SAP, you don't know the normal value on this, no? So if it's
It will be high, sir. Since
120, 113 or something, some places have a, so always ask for
normal range in that lab.
Some places have a 300 and 400 as normal also. Okay.
Yes,
so then it becomes a subtle marker. Okay. So INR, how did you explain that? Is that normal or slightly elevated or?
Sir, it is slightly elevated, sir, 1.4. That can be because of vitamin K deficiency may be one possibility.
Okay, some subtle nutritional deficiency. Okay. Any other reason you can have it? It could be subtle liver disease as well?
Yes, sir.
Very unlikely, no? Very unlikely. Very unlikely. By the time that happens, you'll have other florid manifestations. Okay. What else do you want?
Sir, electrolytes and renal function test also I would like to know, sir.
Why do you want renal function test?
as a to assess the general status of the patient, sir, not particular to the.
Okay, so what do you think about the urea? High, low?
Urea is normal, sir, and creatinine is 0.4.
So
And
if the urea
electrolytes
was
also,
40, the urea was 40,
the patient is having dehydration or recent bleeds, sir.
so bleed can also have. So how this is towards the lower limit of normal, no? This is less than normal, no?
Less than normal.
Muscle mass may be the one reason, sir.
What? So normal is what is normal urea?
Normal urea is up to 30, sir. From
15 to 40. Yeah,
50.
not a bun. It's a urea itself is 15 to 40 or 15 to 35 depending on the lab. So this is actually less. What does that tell you?
Lower muscle mass may be one reason, sir.
Okay, so there might be a subtle malnutrition. Okay, even though the albumin is 4, but I mean, clinical examination is not showing anything. Okay, relatively catabolic patient might have that kind of thing. Okay, and your electrolytes?
Electrolysis appears in the normal limits.
Okay.
No adequate hydration.
So keep saying what do you want next? Yeah.
Sir, I would like to get an ultrasound abdomen as a.
With
What do you want to see in ultrasound?
So don't say as a baseline. You're going to say as a something.
Sir?
What do you
You're
want?
going to say as a something. What are you going to say?
What are you
As a
expecting in
screening
ultrasound? What do you want to see in ultrasound?
So ultrasound, I would like to know the liver status, sir. The echogenicity of the liver, size of the liver, its any nodularity present or not, and status of the any IHBRD.
So don't say it as a baseline. You're going to even for the blood tests. You said I would like to do routine blood tests. In this particular case, none of the things, every single thing was important, wasn't it? Yes. So don't pass it off as you lose your opportunity of showing how smart you are. You know, when you said you knew all the things, but don't call it like casually as yeah. So ultrasound is extremely important here.
Yes, sir.
What all can you know in the ultrasound?
You get all the information.
Yes, sir. Ultrasound.
Why do you expect IHBRD in this patient? What are you thinking?
Sir, portal biliopathy can lead to IHBRD without jaundice.
Okay.
So here the liver is normal size, sir. It is not shrunken or dilated. Echo texture is normal, and there is no IHBRD. Common bile duct is not appears to be dilated, and there is cavernous transformation of portal vein, which is suggestive of EHPVO, sir. And periportal echogenicity is present, which is suggestive of fibrosis, sir. Then gallbladder is distended. There is no calculi. It appears normal. Spleen is grossly enlarged with splenic varices, and there is no ascites. So I would like to go for a higher imaging.
Did you get all the information you wanted, or any deficiency is there?
Yeah, so this is okay for MS level. For MCH level, what all in the ultrasound do you want to know? You mentioned some kinds of.
Are you happy with this ultrasound, or you want some more information by your sonologist?
There's lots of vein, left renal vein. I would like to know, sir, if possible.
Okay. What else?
Left renal vein, then splenic vein, if possible.
Do you want to know other
any arterial aneurysms? Any aneurysms in the splenic artery? I would like to know, sir. Any arterial aneurysms are present?
Is that common?
In long-standing cases, because of hyperdynamic circulation, that can be present, sir.
Okay. But something more important than that?
SMV.
Okay. So
and
other veins, other
IVC.
collaterals. IVC is very crucial. No,
IVC.
You missed that window for IVC. One of the best assessments is by ultrasound.
Yes, sir.
Yeah, you talk about
other named veins. Other named veins have to be evaluated. They have to give a comment, right?
Yes, sir.
So the mesenteric and all you want to know for potential sites of and the renal vein for shunting, and other ones you want to know for cause.
Rule out the other causes.
And then collaterals, other areas of collaterals, you need to look at all those areas. You want to know. So in a case of portal hypertension, if the ultrasonologist is not mentioned, that means he's not looked for it. So you have to ask for it. Do you want to know the portal vein size if it's there?
Yes, sir, but they have written like it is cavernous transformation, sir.
Okay.
If it is present, you would like to know, sir.
Why do you want to know?
We can attempt for radiological interventions, interventional radiology options.
Okay. No, you can diagnose. It's a very sensitive marker of the degree of portal hypertension. What's a normal portal vein diameter?
Less than 10 millimeters.
And anything about the phasic variation in that?
Uh, basic variation of 1 millimeter.
Are you aware of something called phasic variation? What is that and why is that important in portal hypertension?
Basic variation can be increased due after food intake. Yes, no, sir, I'm not aware.
There's a respiratory phasic variation in the portal. So it's one of the first signs in ultrasound of portal hypertension. So when there is even the subtle portal hypertension, the portal veins are maximally dilated. So there's no phasic variation with the inspiration or expiration. So that's the first sign to go, and then it starts dilating. And the degree of dilatation is directly proportionate to
Portal pressure. Sir.
yeah. So for you, you still need to know it, even though you think it's a medical management. But to determine the size of the grafts and all that, you need to know what is the portal vein size. The whole concept of partial shunts is based on that. Huh?
Okay.
Okay. Anything else?
Anything else you want to do?
So you should
Sir,
look for, they should be specifically looking for both sides of the kidney and, they're all normal and all that. Because
Yes.
suppose, you're in a peripheral center and this is the only investigation available to you, you can still go ahead and do a shunt knowing that the opposite kidney is
It's normal.
normal, because you might get litigated only on this stupid reason that it's not clearly mentioned.
Yes.
Because you just said normal, you would have just wanted both, the term both. Yeah.
Yes, sir.
Okay. Anything else?
Sir, I would like
Shiraz?
to.
No, sir, that's okay.
Okay.
Anything else you would like to do?
Sir, I would like to go for a CT photovenogram, sir, as a next image.
So what all do you want to see? What do you want to know on the portal venogram?
Photovenogram is for looking for the status of the portal veins, sir. Then splenic vein.
You already got, you can see the portal veins in this already, no? What status will change?
Intrahepatic.
Intrahepatic. What will change?
The inter-observer variation, we can assess by ourselves. The inter-observer variation.
It's more objective. Is that what you want to say?
Yes, sir. Yes, sir.
It's more objective. I want, if I have the facilities, I would prefer to have that. Okay, for objectivity. Okay,
there we look for the splenic vein diameter. Size of more than 7 millimeters is required for shunting, sir. Then left renal vein diameter.
Why do you want to know left renal vein diameter?
Left renal vein anatomy, sir. Not diameter, anatomy, sir.
Okay. Why? I mean, what in the anatomy do you want to know?
Sir, length and any active collateral is present, already draining to the vein. Any active collaterals are present there, or
then you will not do. It'll always be present, no?
yes. Then the level of left gonadal vein and left adrenal vein.
Is that important? Okay. So most important difference you want to know is is the patency opposite kidney and the distance from the splenic vein to the portal vein. If it's more than 1 vertebral length, you can have some problems intraoperatively. So technical issues you want to look at, and you want to look at the other available veins.
Yes, sir.
Yeah. Okay.
And also, sometimes you have anomalies where you might not be able to.
Right? Aortic renal vein. You know the anomaly of retro aortic renal vein, no? Left renal vein goes behind the aorta.
Sir,
so the left renal vein sometimes goes behind the aorta instead
yes,
of
sir. Retroaortic renal vein is possible, sir.
That scenario, it will be impossible for you to put up a shunt there.
It will be
more difficult, yeah.
Yes, sir.
Very difficult to do.
So Sadiq has asked, what about
endoscopy? Most important.
Where would you time it? Is it needed, not needed?
Sir, this patient is having, she is not having a bleeding at present. She is a controlled bleeder, but she is having.
She's a controlled bleeder.
Actually, she had no bleeding history, sir. But
she never bled. She never bled, right?
But she underwent EVL, sir.
But is it not necessary to know the status of the varices now?
Yes, sir. We need a upper GI endoscopy, sir. Repeat upper GI endoscopy.
What for? What for?
Sir.
What
to look for the present status of the varices, sir.
Only the esophageal varices, anything else?
No, sir. Gastric.
You might have gastric varices which are ready to bleed and you don't catch them, you'll have a problem. So you had some clue. You had some clue in the ultrasound that there weren't any, they didn't mention them, but you didn't ask for them either. So that's one clue you get is if in the ultrasound you can see some a lot of
Very
collaterals
easy.
in that area, you might be able to, guess that an endoscopy might be mandatory. But somebody who's had EVL and all before, so you mean she's had EVL
History of bleeding, sir.
without bleeding?
Yes, sir.
Prophylactic, they must.
Surveillance, prophylactic EVL was
So
done, sir.
prophylactic means what? What do you think would be the thing? Is it unindicated, or there would be something in the varices which would
There
make
will
it? So
there
high
will
grade
be
varices. If you have high
high-grade
grade varices, which
varices.
are, or varices on varices and all those signs, you might do them. So then again, that suggests a high portal hypertension. So you must do endoscopy sometimes reasonably
Endoscopies.
early. Okay.
This is the latest upper GI scope.
Esophagus varices, post-EVL scarring with residual varices are there, sir. Stomach, there is esophagogastric varices type 1 and prominent venous columns noted in the fundus, sir.
So
Duodenum
what is OGV1?
OGV1 is esophageal varices extending to the lesser curvature, sir.
Okay. And what is prominent venous columns noted in fundus called?
OGV2.
IGV1.
Fundus alone is IGV1, sir.
OGV2 is what?
Esophageal varices extending to the fundus.
Okay, whose classification is this?
Dr. Siren's classification.
It's actually Dr. Sarin's modification of Dr. Mathur's classification. Okay. So why do you think the duodenum is normal? Is that normal?
So duodenum, in case of very extensive periportal collaterals, there will be portal duodenopathy also, sir, normally.
So it's much commoner, in fact, to have the commonest site of ectopic varices is actually the duodenum, because you have those veins there taking part in that. So very, very important. The other reason for UGI is to know beyond the usual sites, beyond the OGV1, OGV2, or IGV1, IGV2. You need to know the rest of it. It's not there or not. Yeah.
Yes.
What is downhill varices?
Downhill varices are the direction of flow is from above down.
So where do you get that?
In case of SVC obstruction.
SVC obstruction. Yeah. So that's the only, if you get varices, then it can only be portal hypertension except SVC obstruction if they're downhill. Okay. So CT scan, can we have the CT scan back?
Agostino, just a small comment. I just want to ask you about any drug history. Was she given any beta blocker? Do you think beta blocker has a role in an EHPVO kind of status when you have eradicated varices, or do you do endoscopy? Do you put them on a beta blocker and do nothing? Any idea about the role of beta blockers in upper GI bleed in a cirrhotic or EHPVO patient?
Sir, the volume is low, so I cannot hear.
Sorry,
It's very clear. Beta blocker. Are you aware of the role of beta blockers or not?
Yes, a beta blockers can be used as a prophylaxis.
So should you be asking for drug
Secondary
history? Is
prophylaxis.
what Shiraz is asking. Yeah.
Yes, actually, these patients will be on secondary.
Is that more important for liver disease or for extrahepatic portal venous obstruction as well?
It will reduce the risk of bleeding, sir. So
The question he asked is it more relevant in cirrhotics or more relevant in EHPVO? That's what.
more relevant in cirrhotics.
So the initial evidence was only for cirrhotics, and we used to, give it unindicated probably, but now enough evidence is there that probably even in EHPVO there is a role for beta blockers. I think all of us gave it for so long without any evidence that the evidence came out.
So this is plain CT, sir, to look for any calcifications.
Comment on the liver in the plain CT scan. Can you see anything in the liver in the plain CT? Go back, roll up again. So you will see calcification in the vessels.
So there is no calcification seen in the liver, sir.
Anything else you want to comment on the liver?
Left lobe atrophy. Left lobe appears to be hypoplastic, sir.
Okay.
There is no GB calculi.
Why do you think the left lobe looks like is atrophic in this patient? And what else you are seeing in the liver? You can see these some some black kind of channels, isn't it? What are those?
Can you see the
Those are way.
Is
This,
it normal to see veins in a plain CT scan?
no, sir. That shows increased liver HU, sir. Increased liver HU.
Is it good or bad?
It's norm. I mean, it's good.
So in a plain CT, if you're able to see the veins separately, that suggests that the liver is not fatty.
Yes, sir. Not fat.
If the liver is fatty, become black, and the veins are effaced. So clinically, it's like a good scenario for us. The liver doesn't seem to be, the advancement goes from fatty liver to the fibrosis and cirrhosis. That's the pathway with the imaging it goes in. Here we are seeing the veins clearly, and as you mentioned, the left lobe looks like atrophy, isn't it? What else are you looking at there?
and comparison with the spleen also?
It is appears hyper dense, so it's less likely to be fatty.
Yeah. So
Then there is left lobe GB. There is no calculi seen, sir. Reducence calculi not seen. Then left lobe appears to be less atrophic, sir. Then the spleen, it is enlarged with some calcification seen.
It's a massive spleen, isn't it? It's reaching up to what?
Sir?
What adjective would you call the spleen?
Massive splenomegaly, sir.
And in this kind of splenomegaly, when you were describing that, I was feeling a notch. I don't know where you would feel the notch. This spleen would be literally in the pelvis. You would have to go down, not rather than going from right to left. You would have to go from probably low up to identify the splenomegaly and the notch, the tip of the spleen.
Shiraz, they're given the findings. Actually, they don't actually see the patient. So
yeah, I know, sir. I mean, you should have committed that I would like to extend the examination in this massive splenomegaly. And this for general, not for particularly you, but for general students who appear for an examination of the massive splenomegaly, we must be very careful when we try to describe very subtle findings, in order to gain some marks, we may actually lose the, Okay, now go to the contrast one.
Arterial phase, sir. So
you will have in the clinical examination, because you'll be actually getting the patients, you will have both types of examiners, those who want it to be described as a spleen and those who want it to be described as a lump. So play it safe. It's it's easier to make a schema for yourself, what you want to do, how would you like to face the situation. You can do one which way or the other. Usually it's safer to put it as a lump and then casually, subtly commit to it being a spleen.
yes.
Okay. That usually works in your favor better than, but there'll always be disparity even amongst the examiners. Okay, go ahead. Comment on this.
Sir, this is
Stuff you're not mentioning.
arterial phase contrast CT, sir. Here.
Size, to be honest, if you palpate lump, you say I palpate a notch.
Sir. Hello, sir. I couldn't hear.
Wasn't clear, Shiraz. Just repeat.
Sir, so here the hepatic arterial supplies appears to be arising from cilia with no accessory. There is an accessory left hepatic artery also there, sir. No, there is no accessory right hepatic. There is a accessory left hepatic and normal normal hepatic. I mean, hepatic artery, right and left hepatic artery.
So is that important? You wanted to know so much about the aneurysms and all that. Is that there?
It's actually not needed, sir. We can look for any aneurysms are present or not, sir. There is no obvious aneurysm seen, sir. Then
what else is there?
Then, sir,
Your patient had pain,
Sir, there is
left
no
hypospleen,
there is a
large spleen.
splenic infarct we have to look for, sir.
Yeah.
There is an area of splenic infarct in the lower posterior pole of lower pole of the spleen. That may be the cause of recent onset symptoms, sir. There is no ascites. So I would like to go to the venous phase, sir. Here we have to look for the splenic vein, and here is portal cavernoma, replacing the normal portal vein into multiple collaterals in the hilum. Then
Multiple collaterals everywhere else also, no? You could actually see
yes,
it in
sir.
the plain and arterial as well. And if
Yes.
you notice above the spleen one, you could see in the plain and arterial, but it's a good idea to comment only on the venous phase. That's fine. Okay. You can see, you wanted to know whether there are any spontaneous shunts.
Yes, sir.
The left kidney seems to be squashed by the spleen.
Spleen, sir. Spleen is
And
compressing the
next-
left kidney.
But around that, you can see plenty of
The-
collaterals.
Yes,
Some
sir.
of
I
them which
think
we
there is
decompress.
natural collaterals are there, sir.
That's what you wanted to know, no? How does that
Yes.
change anything?
Actually, when if we are proceeding with surgeries, that will destroy the natural collaterals, sir. So anyway we have to make a.
What surgery are you planning? Dr. Sadiq has asked in the comments that why are you considering a shunt in this case?
So this patient is having symptomatic hypersplenism and symptomatic splenomegaly with hypersplenism.
With significant pancytopenia, okay?
Yes, sir. So
Can you show the splenic vein?
Where is the splenic vein?
Where do you look for the splenic vein?
splenic vein we have to trace from the hilum, hilum of spleen.
Lower border of the pancreas, along the pancreas, no?
Yes, sir. It's the posterior to the pancreas.
Yeah. Can you come?
In that cut which
Go back.
the guy very
Jumping.
helpfully stopped for you at most places when you were trying to say no infarct, he stopped at the infarct. When you're saying no splenic vein, he stopped at the splenic vein. Yeah.
So this one will be. I hope
Okay.
so, sir. This is splenic
Can you
vein.
follow
No.
his pulse? It seems jumping the
Is it double?
what's
No,
the
sir.
top of it?
Or it collateral?
From that one, it's clear, no? When you follow from the pancreas, you'll be able to see better. No? Yeah,
Yes, sir.
there. Yeah,
From
start
SMV
there,
and
then,
it is the junction of SMV and splenic
Yeah.
vein, sir. From
It'll
there it
run-
is going to the.
It'll unlike collateral, it'll be running along the pancreas, isn't it? So if you
Yes, sir.
follow that will definitely be the splenic vein. Some big
Yes, sir.
collaterals may also you might be able to confuse in if you just look at the hilum.
Yes, sir.
Okay, but here you can right.
See
Yeah,
about-
you can follow. Yeah,
Yes.
you can follow that. Yeah.
It dilated or
Sir, its size. It appears not dilated, sir. Not that dilated. Sir. It will be around probably 7 or 8 mm, maybe. Sir. Size I can measure.
It's just a little smaller than the aorta. Yeah.
Can you show the top end of the portal vein? And can we see any portion of portal vein just about outside the liver at the hilum? Go other way. Go up. Go up. No, other way around. Other way around.
So do you have enough information now?
Yes, sir. There is no portal vein seen, sir. So it's
Plan-
and we have to see the left renal vein also, sir. It's anterior to aorta, sir. Left renal vein. It's a single left renal vein anterior to aorta, sir.
And reasonably well placed close to that. Okay.
Yes, sir. Placed close to
Plan.
the.
Plan. You've done enough of CT.
Sir, this patient
Atrial.
is having symptomatic splenomegaly and hypersplenism with no growth retardation and no bleeding. So, in the OGD they have not mentioned about the grading of the varices, sir. If needed, we have to go for a endovascular ligation.
You keep saying vascular. You said about 15 times endovascular ligation, no? Because probably EV other places means so endoscopic varicose ligation, no?
Endoscopic varicose
You said
ligation.
every time you've been saying endovascular ligation. Okay. So be
Endoscopic
careful.
varicose ligation.
Be careful.
Yes,
Yeah.
sir. So, sir, after that, sir, optimizing the patient, I would like to go for this patient for splenectomy with shunt, proximal splenorenal shunts.
Why do you want to do
Why
shunt?
do you want to do shunt in this patient?
He's
Patient
never
never
bled, no?
never bled, and there is a good responded very well to endotherapy.
So one reason is she already she's responding to endovascular therapy. But one reason is when we go for a splenectomy, which is indicated for this patient, there will be loss of natural collaterals, which can aggravate the chances of bleeding. And also we
You have to say
cannot go
very,
for a
no, you
second
have to say
surgery.
very specifically. It's even there in the consensus guidelines. So you have to be very specific about this. The reason the question is asked is you have to come out touch with that.
We cannot go for a second surgery also, sir, because if suppose
Second
the patient
surgery
is,
means?
I mean, we cannot do a shunt surgery later, sir, once we go for splenectomy.
You have to clarify that. Yeah, you're roughly on the right line, but you have to
Yeah.
clarify. Portal vein is already, so if you put it in a way that your junior also understands, the way you said we are wrenching it out of you. The portal vein is already blocked, isn't it?
Yes, sir. Yes, sir.
If you take out the spleen, the splenic vein will be obstructed, isn't
Yes,
it?
sir. Splenic
You'll
vein
have
will be
splenic vein
obstructed. That will
thrombosis.
aggravate the portal hypertension.
So should there be any, she's only, young girl, her whole lifespan, if she gets a portal biliopathy, ectopic varices, or major bleeds which are not controllable by EVL, then we
then
have
we cannot do anything, sir.
so
We
this is
lose
one
the
of the very
opportunity.
few, we are one of the very few indications of a
Shunt,
prophylactic. What's the term is prophylactic shunt.
prophylactic shunt.
So why do we not do prophylactic shunt in liver disease, for instance?
Sir, liver disease prophylactic. We are not doing splenectomy for liver disease. I mean, prophylactic tips is possible, sir.
So suppose there's a severe hypersplenism in liver disease, and you're going to do splenectomy. Would
Shunt
you like?
surgeries will aggravate the rate of liver failure, sir. That will divert the portal flow away from the liver.
Is
That
that
will
is that evidence based or just your feeling? Are there any trials on this?
trials.
So these are actually the first surgical trials ever done. There are 3 trials showing no different, they were done with the intent of seeing whether, so bleed did reduce, but there was no difference in mortality in all 3 trials. There's only one trial which had a mixture of liver disease and extrahepatic, I think that was from Japan, which showed some benefit for prophylactic, but all the 3 ones done for liver disease alone showed no benefit. 60s, they were the first surgical trials, so you should know about them historically. So 3 trials, even though they're dated now, but I think the evidence in that is they die of liver failure. You just change the mode of death. So prophylactic is not indicated.
Yes,
So if you can do any other methods of varicose control and shunt only if all those fail, and with the proviso that you need to do all the anti-encephalopathy measures and all that. Okay, so can you tell us quickly what are the indications of shunt before we open up to everybody else?
One is intractable bleeding, which cannot be controlled by endoscopic means, sir.
So say this last, because you'll get stuck in this. I've said so many times now, always say this point last.
Yes,
Whenever you're asked for indications, don't automatically say emergency, elective. Say the ones which are incontrovertible first, so that you get them out of the way. If you get stuck in the others, if in ulcerative colitis you get stuck in intractability, nobody knows that you lost your window of opportunity of showing your smartness. So say the incontrovertible ones first.
Yes, sir. So symptomatic splenomegaly, hypersplenism, growth
Again,
retardation.
That's a very those are all soft ones. No, what are the definite indications of
Growth retardation.
So best indication is growth retardation.
Retardation also is
It's also soft
soft
again.
indication.
We use it as a soft marker, if there's a subtle hypersplenism along with growth retardation, we would all do shunts, but it's not the number one indication. So tell us the most important where only shunt can be done, nothing else. I said, if I give beta blockers, I can reduce.
Portal biliopathy, sir.
So portal biliopathy, ectopic varices, portal biliopathy. What else? Why portal biliopathy?
Portal biliopathy leads to biliary obstruction that will long time lead for secondary biliary cirrhosis also. And that can.
Okay, but for treating the biliopathy itself,
shunt will resolve
shunt
the
can
biliopathy.
actually resolve a few cases of which are only because of the venous compression. This one probably has fibrosis. So why should you do the shunt? See, this one says very clearly that there is fibrosis in that area. No.
Periportal area fibrosis is.
So will the shunt help?
Less.
Is it indicated? Not indicated then? You're looking confused, you don't know. It's still indicated. Why?
That reduction in venous diameter will be better in long. The pressure effects will be less.
Can you do a shunt? Can you do a biliary bypass without doing a shunt?
No, sir. Because of very.
You have to do it as a staging procedure to reduce the collateral pressure. Some people do a direct one, but only if there is no available shuntable vein.
Yes.
If you have the vein available, you try with a preliminary shunt. Only if that fails, or if that's not available, or there's already splenic vein thrombosis, you can try with a much higher risk of problems. You can try. Dr. Yadav has written, does size of varices matter?
Size of varices in where around.
So yes, size matters. No, the size tells you. So one form of grading is also based only on size. No, the higher, just like portal vein, the size of the varices tells you the risk of bleed in them.
Yes.
In fact, to R to the power of 4, isn't it? Your the formula. So even a small change in diameter of a varix can increase exponentially the risk of bleed. So it is very size of varix is very important. He's also said splenectomy alone doesn't increase portal hypertension. However, there are chance of whole axis getting thrombosed. Even SMV can get thrombosis. So exactly that same point, that you can have extension of that splenic vein thrombosis, and even a mesocaval may not be possible later. So again, very important point. Pradeep, should we open it to the others?
Yeah. So in this patient, what is your final decision? You want to do splenectomy and shunt?
Yes, sir. I would like to go with the splenectomy and shunt.
So the indications in this patient, what are the indications you want? Why you want to operate? Why I said I said I'll go for conservative management. What are the indication in this patient?
So this patient
there is no symptomatic hypersplenism in this patient. There is no bleed in this patient. Why?
So she is having symptomatic splenomegaly, sir.
So that's not a very good term. So say splenomegaly with pressure symptoms. Okay.
Yeah. The only indication in this patient is that there's acute infarct. Then she had a early satiety. She's not able to eat food and discomfort. So basically, it is because of the huge size of the spleen, producing symptoms. You are planning surgery in this patient.
Yes, sir.
So otherwise, suppose if this is not present, this patient, how will you manage?
And then one more thing, that anemia 7.9 in a
7.9H.
Yeah, it's not something that we want to have. So if she's saying she doesn't have symptoms, but we know that she's definitely anemic, right? It's not going to be a good for her long term.
Symptomatic hypersplenism. Probably anemia is the only one which could be nutritional or hypersplenism, because she is not able to early satiety. She is not able to eat.
Intake may be inadequate.
Is the platelet of 50,000 important?
When we are 50,000, when we are planning for surgery, above 50,000 is okay.
So let me rephrase that. If the same 50,000 is there in a liver disease patient, which one are you more worried? So liver disease, yes.
Liver disease will be more worried, sir, because of
why?
Why?
Not for that. Just for the platelet. Everything else is normal. Clotting is normal. Only platelet wise, the platelet function itself is also abnormal. So you need more. So when you started talking about when you're going to do procedures, 50,000 is actually probably okay for, because all the platelets are normal. So although our normal is 1.5 lakhs, up to 50 is completely okay. If there is, going below that, spontaneous bleeds will happen less than 30. If the platelets are normal, but in liver disease you may have even a normal platelet count, even 1 lakh, many of them may be abnormal, so the platelet function will be abnormal as well. Okay.
And there will be
So
other
I think
function also
uh,
in disease patients. Yeah.
Shiraz, can we open
Yeah,
it?
please. Yes, sir, please.
Yeah, I think you're overall okay, but see, this is straightforward diagnosis. This is a straightforward case. I think you should not fumble in whatever questions Puneet has asked you, right? Because diagnosis is not a problem, and it is a straightforward case, and it's a common case. So examiner expects you to perform much better than what you have done, but you have done well, okay. So, but there is a scope for improvement on your performance. So now we can have other faculty.
I think Sadik
Professor
is raised his
Sadek
hand.
is there, Professor Kapoor is there, Professor T.D. Yadav is there.
Sadik has raised his hand. Sadik.
Sadik, go ahead, Sadik. You can unmute and then.
Can you hear me?
Yeah.
So see, Anthony. So Anthony, what I realized is, as Pradeep said, that diagnosis is not a problem. And you also very quickly made up your mind that what you have to do as a treatment. And therefore you lost track of how to evaluate the patient and prepare the patient, understand the status of the disease. So you quickly went on to doing a CT scan before in a portal hypertension patient, looking at varicose status and things like that. So you go stepwise. When it comes to the decision making, that's the time you start making a decision rather than have a preconceived idea that I want to operate this patient. The second part is when you're looking at CT scan, again, it was a very haphazard. I mean, you have to be very specific that you are mentioning left portal vein, whether it is patent or not. Why? Because you can do a shunt to the left portal vein from the superior mesenteric vein. You also did not mention this, how is the superior mesenteric vein? Is it patent or not? We've not scrolled down to look at that. Splenic vein, you did mention we are seeing, but the diameter of the splenic vein was not clearly mentioned, so as to understand how effective would be the shunt surgery in that, right? So if you're looking at the CT scan, you have to mention all these things before taking up that this is the, because you may have an alternative shunt you may have to do if it is. The third point is that we are talking of options, and at this level, you should also know that they are only for hypersplenism. Now there are options of partial splenic vein embolization and all. So immediately rushing on to surgery and shunt, which probably we all may consider doing seriously, but options of partial splenic vein embolization and all should be kept in mind and discussed with the patient, and you should also consider that before offering one treatment to the patient. But I think, since the case was straightforward, you had so many other things to think about in that, and that should have been done in a much more organized manner, I feel.
Dr. Kapoor.
Yeah, good morning. So, as was pointed out, symptomatic splenomegaly can cause a feeling of a drag because of the weight of the spleen, especially when the child is standing or is active. It could be an acute pain of an infarct, or it could be the feeling of satiety, early satiety, postprandial fullness, rarely leading to nausea and vomiting. So that is how you should describe symptomatic splenomegaly. Now in this, I missed the initial details of the history, so maybe I'm wrong, but probably there was no history of GI bleed. So if you have only splenomegaly and no GI bleed, then I think at some stage in the discussion, some hematological disorders also should come into discussion, and you would like to rule them out before making a diagnosis of portal hypertension. Clinical diagnosis of portal hypertension is splenomegaly and GI bleed. If there is no GI bleed, then hematological causes should be discussed. In the hemogram, you should have yourself pointed out that the retic count is missing. And whenever you have a significant splenic disorder or a possibility of a hematological disorder, you should on your own say, I want a complete hemogram with peripheral blood smear and all the red blood cell indices. They are important because then the counter question was asked. Again, hypersplenism can be clinical or it can be hematological. Some students say biochemical. It is not biochemical. It is hematological hypersplenism. Ultrasound. You said I would like to get an ultrasound done. No. When you are dealing with portal hypertension, you have to say, I will get an ultrasound with Doppler. It is the Doppler which gives you all the information, not just the ultrasound. And I hope you know the difference. In a 14-year-old girl, I personally would prefer an MR rather than a CT, because MR can give you all that information which you are going to get on CT without causing so much of irradiation to a young girl. You all should know, and you should describe in that way, that pancreas has 3 borders and 3 surfaces. It has an anterior border because it is triangular in shape. It is a superior border and it has an inferior border. The 3 surfaces are posterior surface, antero-superior surface, and antero-inferior surface. The splenic artery runs along the superior border of the pancreas. The splenic vein runs on the posterior surface of the pancreas. That is how you should describe it. You said left renal vein is anterior to aorta. That is normal, isn't it? So you described the detail of anatomy when it is abnormal. You should have said left renal vein is normal in position. You were asked, what is your plan? And you started summarizing the case again. Of that, I have said n number of times, when a question is asked, please answer the question first and then give the justification. So you should have said, my plan is to operate upon this patient. I plan to do a splenectomy and a shunt, and the reasons are 1, 2, 3, 4. Now, in this particular case, the indications for surgery, you should have said that it's a massively enlarged spleen, and which is causing.
I think we lost him.
We lost him, yeah. Sadik, you still have your hand up? Or TD?
TD?
No, good morning, sir. All the points have been discussed. I just want to add to further resident that when pathophysiology in portal hypertension is very, very important. I think we should read very carefully and meticulously, repeatedly. When we have a portal vein thrombosis at the earlier age, when liver size is small, the blood circulation is significantly increases in the hepatic artery. As a result, there is a surface area of liver is low. So what happens that there is some sort of necrosis in the liver area, and then there is a regeneration. So these are the reasons why there are some changes on the ultrasound in the liver, and that is the reason for the some patient in advanced stage there might be some little bit of decomposition, especially after surgery, and also size of the varix. Then a portal hypertensive gastropathy was not mentioned in this one. So I think these are the things. Most of the other things have been already been told. Thank you, sir.
I think Dr. Kapoor is back. We can.
Sorry, I think I got disconnected in between.
Yes.
Yes, sir. Go
I
ahead.
don't know at what point. I
You said
think
the indication,
ultrasound.
massive splenomegaly.
Okay.
Indications
So
for
yeah,
surgery in
I
this
was
case.
saying that indications for surgery in this case would be a massive spleen which is crossing the midline, which is symptomatic in the form of causing early satiety and probably pain or drag, and it has already formed some infarcts, and a very low platelet count, although it is just above the cutoff of 50,000, which Dr. Puneet Dhar mentioned, but it is very low in a young female who's going to have all her menstrual cycles and deliveries. So I'm little concerned about it. So that is a soft point, but it should probably come in discussion. So students, please send me a mail, bkkapoor.india@gmail.com. Write portal hypertension in the subject of the mail. Thank you.
If there are no more comments, can we wind up, sir? Puneet?
Yeah, yeah.
Thank you, Puneet. Thank you, Shiraz, and thank you, other faculty, and thank you, Agostino.
Thank you, sir.